Speaker எல்லாரும் ஸ்பீக்கரையும் ஆஃப் பண்ணுங்கப்பா. அதுவும்
Hello, good afternoon, everyone.
நீங்க தான் வச்சிருக்கீங்க.
Thank you. Welcome, everyone, to the next edition of Chengai Pediatric Meet. So, on behalf of IAP Chengalpattu, I'm glad to welcome everyone. Apologies to everyone, especially Sundari ma'am, HOD and Professor Balaji Medical College. NMC inspection is going on in SRM. That is why we are not able to join. I hope Balaji Medical College can take over and host. Welcome everyone to the Chengai Pediatric Meet. Please proceed. Thank you. Thank you for joining. Dr. Kritika ma'am.
Harsha, are you able to hear me?
Yes ma'am. Please proceed ma'am. Please start ma'am.
Harsha?
Yes ma'am. Kekudha ma'am.
We have confirmed.
Please continue ma'am.
எனக்கு கேக்குதுப்பா, நான் பேசுறது கேக்குதா?
Yes ma'am. Yes ma'am. கேக்குது ma'am.
Hello? கேக்குதாப்பா?
Audible ma'am. It's audible.
Okay. It's getting disconnecting and connecting. Good afternoon and warm welcome to all. It is our privilege to host this 21st IAP Chengalpattu Pediatric Meet at Sri Balaji Medical College. On behalf of our institution, I extend a warm welcome to all the esteemed delegates, presenters, and moderators joining us today. We are honored to have representatives from Chettinad Medical College, Dr. Kamakshi Memorial Hospital, and SRM Medical College with us. Your participation and expertise are truly valued, and we are excited for the insightful discussion and knowledge sharing that will take place. Without further ado, let's move ahead and invited our first case presenter, Dr. Tawheed Bashir.
Good afternoon to one and all present here. I'm Dr. Tawheed, Junior Resident from Department of Pediatrics. I'll be talking about fevers, floods, and fury, a conundrum in a tropical infection. I'll be talking about fever, floods, and fury, a conundrum in a tropical infection. A 14-year-old adolescent boy, second born to non-consanguineous parents, residing in Washermanpet, Chennai.
அங்க ரூம்ல நெட்டும் கிடைக்காது, அதுக்கு லைட்டே உட்காந்துட்டு
Full screen. Full screen.
உட்காந்துருவேன்.
Hello.
Good afternoon. I'm Dr. Tawhid, junior resident from Department of Pediatrics. I'll be talking about fever, floods, and fury, a conundrum in a tropical infection. A 14-year-old adolescent boy, second born to non-consanguineous parents, residing in Washermanpet, Chennai. Informant was mother with good reliability, presented with chief complaints of fever for 14 days, abdominal pain for 7 days, and vomiting for 3 days. History of presenting illness. Child was apparently well 14 days back, after which he developed fever, which was high grade and intermittent, associated with chills. Interfebrile period, child was active. Fever relieved with medications, and fever was not associated with any skin rashes. Child also complained of abdominal pain, which was last 7 days of the illness, present all over the abdomen, which was non-radiating, and there were no aggravating and relieving factors. Child also complains of vomiting for 3 days, 2 to 3 episodes per day, non-projectile, consisted with undigested food particles, which was not blood stain or bile stain. History of myalgia was there for 5 days. History of lethargy for the last 2 days of the illness. No history of joint pain. Past history. History of hospitalization was present for the current illness. Child was treated on OPD basis for the first 8 days of illness. He was admitted in private hospital on day 8 of illness with presenting complaints of fever and abdominal pain. Upon admission, the patient was initiated on intravenous fluids and antibiotics. Injection ceftriaxone for 5 days for suspected bacterial infection. Despite ongoing treatment, the patient's family opted for discharge against medical advice on day 14th of illness after a hospital stay of 6 days. Antenatal, natal, and postnatal history was uneventful. History was normal. Developmental history was normal. The child is studying in 9th standard with good scholastic performance. Immunization history was normal. Immunized up to age according to national immunization schedule. Family history, there were no history of similar complaints of chronic illnesses in the family.
இன்னைக்கு போய்
On
ஏதோ
examination,
நாளைக்கா இன்னைக்கு என்ன டே
on examination, child was conscious,
நாளைக்கு ஜாயின்
sick looking,
நெக்ஸ்ட்
toxic. Child was febrile, hydration was fair. Child had no pallor, icterus, cyanosis, or no,
இது உன்னோட டைப் தானே இவரு
no generalized lymphedema.
கால் பண்றாங்க
Sorry for interruption. I think someone is not muted. Kindly mute yourself, please.
On examination, child was conscious. Child was sick looking, toxic. Child was febrile. Hydration was fair. Child had no pallor, icterus, or cyanosis, no clubbing, no generalized lymphadenopathy, and no pedal edema. No skin rashes or petechiae. No eschar was present. BCG scar was present. Oral cavity was normal. Vitals pulse rate was 120 beats per minute. Normal volume, regular rhythm. No special character. No radial or radiofemoral delay was present. Respiratory rate was 28 per minute. Axillary temperature 104.4 degree Fahrenheit. Blood pressure was 110 by 70 mmHg, which was falling under 58 to 98 centile. Anthropometry, height, weight, and BMI was within the normal percentiles, according to IFP centile charts. On systemic examination, abdomen was soft and non-tender. Liver was palpable 4 centimeters below the right costal margin. It was firm in consistency, smooth surface, and smooth borders. Liver span was 12 centimeters. Spleen was palpable 3 centimeter below the left costal margin, which was firm in consistency and non-tender. All other systems were normal. With this above investigations and examination, our provisional diagnosis was malaria, dengue, scrub typhus, and enteric fever. Investigations, complete blood count showed leukopenia and thrombocytopenia with hemoglobin of 10.2 gram per dl. Peripheral smear showed microcytic hypochromic anemia with thrombocytopenia, where WBC were normal and no malarial parasites were seen. Urine microscopy was normal. And other investigation, NS1 and IgM dengue done by ELISA was positive. IgG was negative. IgG dengue was negative, and IgM scrub, Vidal, and malaria test was negative. And test for leptospirosis also was negative. Blood and urine culture showed no growth. In view of persistent fever spike and bicytopenia, we suspected dengue with secondary HLH. So the next investigation to rule out organ damage or any hyperinflammatory markers, set of following investigations were done and found to have increased ferritin levels and hypofibrinogenemia was present. A liver function test revealed transaminitis with hypoalbuminemia with increased conjugated bilirubin levels. And USG abdomen showed splenomegaly and minimal ascites. Other radiological investigations were normal. To confirm the diagnosis of dengue-associated HLH, HLS 2004 diagnostic criteria should be met, which is 5 out of 8 among these parameters, which is fever lasting more than 7 days, splenomegaly, bicytopenia, any 2 cell lines should be affected, hypertriglyceridemia or hypofibrinogenemia, or low absent or natural killer cells activity. Ferritin should be more than 500 nanogram per ml, and soluble CD25 more than 2400 units per ml, or demonstration of hemophagocytosis in the bone marrow, spleen, or lymph node. With above investigation, the child's illness satisfied 5 out of 8 HLS 2004 criteria, which was fever for more than 7 days, bicytopenia, splenomegaly, hypofibrinogenemia, and hyperferritinemia. We sought hemato-oncologist opinion, who also entertained the diagnosis of dengue-associated HLH and suggested bone marrow and high-performance liquid chromatography in view of severe MCHC anemia. Bone marrow biopsy was performed under sterile condition and under aseptic measures. Bone marrow findings reveal no mild hypocellular marrow with features of regeneration, and no blast cells and no hemophagocytes were seen. Bone marrow culture showed no growth. With the series of complete blood count, which shows a progressive anemia starting on baseline 10.2 grams per DL to 7.9 grams per DL on day 21 of illness. And child also had leukopenia throughout the course. And neutrophil count dropped from the day of admission to day 21 of illness. Course in the hospital. Child with dengue associated HLH. A child had persistent fever with neutropenia. So empirical antibiotics with injection piperacillin tazobactam was started, and child showed spontaneous resolution after 48 hours of injection piptaz. And we continued till 7 days. We continued till 7 days of the course. Child improved clinically and was discharged and followed up. On follow-up, child was healthy and counts had returned to the normal baseline. Coming to the discussion, this case is taken for the discussion because of the rarity of the presentation. Overall incidence of HLH is 1 per 1 lakh. Overall incidence of HLH is 1 lakh, 1 per 1 lakh per year. The incidence of dengue associated HLH is 0.44 per lakh per year. The case fatality rate ranges from 4.5 up to 43%. Prompt treatment by clinicians. Coming to the discussion, coming to the pathogenesis of dengue fever with HLH. Infection with dengue virus causes activation of cytotoxic T cells. This activated T cell leads to release of cytokines, and this cytokines in turn causes activation of macrophages. These activated macrophages have mainly two functions. One, to release more cytokines, which is example this interleukin 1 and interleukin 6, which releases ferritin and giving rise to hyperferritinemia, and also releases plasminogen activator, which causes destruction of fibrinogen leading to hypofibrinogenemia. This cytokine also suppresses lipoprotein lipase, which gives rise to hypertriglyceridemia. The second function of activated macrophage is to the second function of activated macrophage is hemophagocytosis, which can be demonstrated in bone marrow and leads to cytopenia. And this activated macrophage infiltrates spleen and liver, which causes hemo and hepatomegaly. This is a diagnostic criteria already been discussed. Coming to the management, there is no optimized standard for the management of dengue with HLH. Studies have shown that the cases were managed based on clinical discretion. Clinician discretion. Treatment option includes the most common is short course high dose IV steroids, just dexamethasone 10 mg per meter square for 3 to 5 days daily and tapering over 2 to 8 weeks. The second common is IV methylprednisolone, a dose of 2 mg per kg daily for 3 days, followed by oral prednisolone 1 mg per kg for 2 weeks and tapered over 6 weeks. IV immunoglobulins 1 mg per kg per day for 2 days also can be given. IV etoposide 150 mg per meter square given twice weekly for 2 weeks, and it is rarely used. And combination of steroids and immunoglobulins can also be used for the treatment. No chemotherapeutic agents and hematopoietic stem cells transplantation were reported in the secondary HLH. Supportive care. Some cases recovered with supportive care alone, as seen in the study done by Nandakumar et al., where among 28 cases, 18 recovered with supportive care alone. Carry home message. Dengue associated HLH is often underdiagnosed. Severe dengue with no effervescence after 7 days with anemia and no superadded infection should be suspected for HLH. While main courses on managing capillary leak and bleeding, dengue-associated HLH demands attention. Dysregulated macrophage activation and cytokine storm poses challenges in diagnosis and management. Knowledge of dengue-associated HLH helps to prevent mortality by timely administration of high-dose steroids in selected patients. Future research should focus on prognostic factors and treatment optimization in dengue-associated HLH. Thank you. These are my references.
Thank you all for patient listening. Is there any questions, queries from the audience? Ma'am, sir, like, are we audible? Is there any question from the audience? So I think we don't have any questions. So let us conclude it by saying, so any child with a tropical infection with a prolonged fever than expected in the course with falling hemoglobin without evidence of intravascular hemolysis, think of some ongoing hyperinflammatory state. So there is a conundrum in labeling the term to be HLH mass or cytokine storm syndrome. The treatment remains the same more or less. In a very critically ill child, a short course of steroids or immunoglobulin would be life-saving after ruling out malignancy or deep-seated infections. In a very stable child, you can wait for spontaneous recovery by giving supportive care. Thank you.
Good afternoon, everyone. Myself, Dr. Shivashankar from the Department of Pediatrics. I'm going to present the topic regarding hemolytic anemia.
Are you going to share the slide or can we do it? You want us to share?
I will share the slides now. Yes, ma'am. My slides are visible, ma'am.
Yes, are the slides visible, ma'am?
Lights are visible.
Okay.
You can start.
Good afternoon, everyone. I'm Dr. Priyanka from Dr. Kamakshi Memorial Hospital. I'm going to present a case of an unusual complications of a simple procedure. Chief complaints, a 12-year-old female child referred to a pediatric emergency in view of right shoulder pain for 1 day, abdomen pain for 1 day, and giddiness on sitting and standing position for 1 day. On arrival to pediatric emergency, the child was lethargic with a heart rate of 120 breaths per minute. Her respiratory rate was 30 breaths per minute, and she maintained a saturation of 100% with oxygen. Her blood pressure were 97 by 56 mm of Hg. Her peripheries were cool below ankle with a pulse volume of 3 plus and 1 plus and CRT of more than 3 seconds. On general examination, the child had multiple scratch marks, pallor present, icterus present, and there was no signs of liver failure like ecchymosis, PTK, spider nevi, distended veins or flapping tremors. No cyanosis, no clubbing or lymphadenopathy were present. Her CPG was 149 milligram per deciliter. The child physiological status, her airway was stable with effortless tachypnea. The child was in shock and an altered level of consciousness. On systemic examination, per abdomen, soft tenderness was present, guarding pleasant, and there was hepatomegaly with a liver span of 18 centimeters. There was no splenomegaly. Rest of all the systemic examination were normal. We arrived at a provisional diagnosis of compensated shock, and the child was resuscitated with oxygen via NRM and large IV bore cannula secured, and isotonic normal saline bolus of 20 ml per kg was initiated. On arriving to the background history, the child was born out of a 4-3 consanguineous marriage, and there was history of intrahepatic cholestasis of pregnancy was noticed in her mother. The child was developmentally normal and she was immunized up to age. The child was apparently normal till 12 years of age. On 23/9/2024, the child presented with acute febrile illness associated with sore throat, bilateral enlarged tonsil, and on examination, icterus was present. The child eventually developed itching, for which child was evaluated. Investigation done on 26/9/24 showed a total count of 14,600 with a raised total bilirubin of 4.3 milligram per deciliter and direct bilirubin of 4 milligram per deciliter. Her GGT, SGOT, and SGPT were within normal limits. In view of direct hyperbilirubinemia, the child was further evaluated. Ultrasound abdomen done showed a mild hepatosplenomegaly with cholelithiasis. And to rule out the cause of viral hepatitis, further investigations were done, which showed Epstein-Barr virus IgM was positive. A child was in follow-up and serial LFT was taken, which showed a decreasing trend of total and direct bilirubin of 3.6 and 3.2 milligram per deciliter. Child was diagnosed as Epstein-Barr virus hepatitis and treated with syrup HV52 and UDCA. Child was in regular follow-up with the pediatrician, and this was the serial investigations was done. In October 2024, the child again started to have an itching with jaundice, for which total bilirubin and direct bilirubin was done, which showed a raising trend again of 8.2 and 7.8 milligram per deciliter. In view of increasing trend of bilirubin level, the child was referred to a pediatric gastroenterologist, and child was suspected as benign recurrent intrahepatic cholestasis, treated with tablet Irsocol and multivitamin. Child was in regular follow-up. Again in December 2024, the child started to have a severe itching, and the investigation done showed a total bilirubin of 23 and direct bilirubin of 22.4. In view of persistent symptoms and the progression of jaundice, the child was admitted and planned for liver biopsy. Pre-procedure laboratory parameters done were normal. Liver biopsy done on 20th/12/2024 showed a mild portal fibrosis with septate. There was no bridging fibrosis, no features of cirrhosis. Impression, benign recurrent canalicular cholestasis with FIC1 deficiency was present. And post-liver biopsy, ultrasound abdomen was done on day 0 and day 3, which showed no hematoma and there was no perihepatic collection. The child was discharged with tablet Visolon and tablet UDCA. Child was absolutely normal post-procedure till 12 days. But on day 12 of post-procedure, child started to have a complaints of postural change. And on day 14, the child developed complaints of right shoulder pain associated with a severe abdominal pain. Child was admitted in Dr. KMH Siriseri. Child was evaluated. Ultrasound abdomen showed a free fluid in the pelvic cavity, and for which ascitic tapping done, where the bloodstained fluid was drained. Following which, the child was taken up for CECT abdomen, which showed a moderate hepatomegaly, ascites, and hemoperitoneum. And in view of hemoperitoneum, the child was referred to Dr. Kamakshi Memorial Hospital, Pallikarne. Provisional diagnosis, hemoperitoneum, hemorrhagic shock, and benign recurrent intrahepatic cholestasis. After initial stabilization in the pediatric emergency, the child was shifted to pediatric ICU, where child was continued on oxygen by a non-rebreathing mask at 10 liters per minute. Bladder was catheterized. In view of hemorrhagic shock, injection tranexamic acid was given, and child was started on PRBC transfusion. Antibiotic injection piperacillin plus tazobactam was started. This was the initial investigation which was done, which showed a HP of 9.1, and the repeated value after 12 hours showed a falling trend of hemoglobin of 5.8 gram per deciliter, and her total and direct bilirubin was 7.5 and 6 milligram per deciliter. Rest of all the low function tests were normal. Her coagulation profile is also normal. The CECT abdomen was reviewed with our radiologist, which showed a massive hemoperitoneum. All over the peritoneum was present, and there was a large perihepatic hematoma was present. And you can see an active ooze of contrast was seen, which is probably from the right intercostal artery in the 9th and the 10th rib space. And there is also mild hepatomegaly and cholelithiasis was seen. In view of hemoperitoneum, the pediatric surgeon opinion was obtained, and in view of active arterial bleed, rapidly expanding hemoperitoneum and sinking hematocrit, child was immediately taken up for emergency diagnostic laparoscopy and proceed. Child was shifted to operation theatre immediately. Under anesthesia, under ETGA with local anesthesia, in child on supine position, 10 mm camera port plus 5 mm working port was placed. Findings noted were gross hemoperitoneum was present, large blood clots all over the cavity, mainly on the liver, Morrison pouch, and the pelvis was present. Active arterial bleed ooze was noted on the parietal wall.
இல்லாட்டி பேஜ்ல மாத்துங்க அந்த பாப்பாவோட நீ ஃபீமேல்
This almost all the peritoneal cavity were surrounded with clots, and this was a massive clot which has been taken up from above the surface of the liver, and you can see an active arterial ooze on the parietal wall. The bleeding was cauterized. And following which suturing was done. And these were the massive clots which has been removed by endobag. Peritoneal wash was given, and hemostasis was achieved. Diagnostic laparoscopic and right intercostal artery ligation. Bleeding was cauterized. Hemostatic ligature placed by intracorporeal suturing. Hemostasis achieved. Clots removed using endobag. A thorough warm saline wash was given. DT placed in the Morrison pouch, and wound closed in layers with Vital 2.0 and skin closed with Ethylon 3.0. Dressing was done. Post-operatively, on post-operative day 1, the child was mobilized and started on oral diet on post-operative day 2. On post-operative day 3, the drain was removed. On post-operative, child had a bradycardia for which cardiologist opinion was obtained. ECG, echo, following which Holter monitoring done was normal. Child was continued with IV antibiotic and injection vitamin K was given. On post-operative day 4, ultrasound abdomen was done, which showed a minimal free fluid in the pelvis and Morrison pouch. Mild hepatomegaly and cholelithiasis was present. This was a post-operative investigation which showed hemoglobin. Hemoglobin was maintained at 9.7 gram per deciliter, and her total bilirubin and direct bilirubin was in a falling trend of 8.7 to 8.5 milligram per deciliter. Child was hemodynamically stable, tolerated oral feeds well, and genetic counseling is given for the parents regarding whole exome sequencing and CNV analysis after 4 weeks, and child was discharged on the post-operative day 6. Discussion. Liver biopsy is a gold standard investigation for diagnosing various liver disorder, and it also has a prognostic value. Indications of liver biopsy include histologic identification of various hepatic conditions, unexplained hepatomegaly, unexplained elevated liver enzymes, space-occupying lesions, drug-induced liver injury, and intrahepatic cholestasis. The most common type is an ultrasound-guided percutaneous liver biopsy, which is generally considered safe and very low complication rate. Mortality rate following a liver biopsy is 0.2%, and the most severe complication reported were hemorrhage. Complications of liver biopsy, the total percentage of complications is 0.75%, out of which the most common is pain, which is 84%, followed by bleeding, hemothorax, pneumothorax, septicemia, biliary peritonitis, intrahepatic arteriovenous fistula, liver rupture, and death. Clinically significant hemorrhage includes a decrease in a hemoglobin of more than 2 grams per deciliter, hemodynamic instability with radiologic evidence of bleeding necessitating blood transfusion. Incidents of bleeding post-liver biopsy were reported well 0.35%. Almost 95% of the bleeding complications will occur within 24 hours, and the mortality rate due to bleeding is 1 in 10,000 of population. Factors associated with the risk of bleeding includes bleeding disorder or impaired hemostasis, cirrhosis, malignancy, renal failure, ascites, and technical issues like high number of needle passage, use of a large needle, and blind technique. And high-risk patients for delayed bleeding includes low platelet, hydrothorax, and ascites. Types of bleeding complications were, according to the duration, it could be an acute or chronic, which is less than 24 hours, more than 24 hours respectively. If it's due to the site involved, it could be intraperitoneal, intrahepatic, or hemophilia. Intraperitoneal bleed accounts for 0.7%, with secondary to, most commonly, secondary to liver laceration, perforation of the portal vein, hepatic vein, aberrant arteries, major intrahepatic blood vessels, and intercostal artery. The main presentation include abdomen pain with hemodynamic instability and a drop in hemoglobin. Other types include intrahepatic or subcapsular hematoma. The patient will present with pain, tachycardia, and a raise in the serum transaminases. And hemophilia, the triad is GI bleed with jaundice and right upper quadrant pain. Patient mostly present on the 5th day of post-biopsy, and it's mostly arterial in origin. Delayed bleeding is very rare with a duration of more than 24 hours, and the longest latency period reported is 17 days. Causes of delayed bleeding includes premature clot dissolution due to liver disease associated with hyperfibrinolysis, rupture of liver capsule, rupture of intrahepatic hematoma, pseudoaneurysms, arteriovenous fistula, arterial biliary fistula, and clot dislocation. Conclusion: a delayed bleeding after liver biopsy is very rare, and clinical evidence of hypovolemia in the post-biopsy setting reflect hemorrhage unless proven otherwise. Hemorrhagic shock in a liver biopsy settings requires immediate intervention, emergency laparotomy to prevent morbidity and also mortality. Thank you.
I would like to come.
Mic, no. No, it's on now.
Congratulations for presenting this excellent case, doctor. You have created an awareness of how an liver biopsy has to be done, always guided by an ultrasound. And delayed bleeding is one of the very rare complications. I congratulate you for timely identification and ligation of the intercostal artery. Was the bleeding due to an apparent intercostal artery or the presence of a collateral? Because usually intercostal bleeding is very, artery bleeding is rare.
Yes, ma'am.
Was there an apparent?
Sorry, ma'am, I can't hear you.
Was the bleeding due to an apparent intercostal artery?
Ma'am, we have our surgeon, Dr. Arun Prasad sir, on the call, ma'am. He will take the questions, ma'am.
Hi, everyone. In this particular case,
Due to any apparent intercostal artery or due to any collateral?
No, ma'am, it was not that way. It was the actual regular intercostal artery. The normal course itself was probably got injured.
Probably the needle which was passed is a little bit wider bore. So probably the probable cause would have been we should, when we inject the needle, the lesson should be like we should go to the upper border of the lower. That is where we have to inject. So probably the because of the higher bore of the needle, the needle probably would have grazed through that intercostal artery. So that was probably bled in this case. There was no evidence of any aberrant artery in CCT or anywhere we were able to notice.
There's a chat box question. What was the PT and APTT INR pre-procedure? I think it was normal because she elaborated all the functions were normal prior to the biopsy. And what is your management for the high direct hyperbilirubinemia which may cause itching to the child? What is your final answer for this condition? I would like to question the presenter.
Ma'am, the child has been discharged now, ma'am, and is in follow-up now. Because the child is out of a fourth degree consanguineous marriage, the parents have been told to come back and review with us. We have also advised the whole exome sequencing for them, ma'am. The liver biopsy is showing the BRIC features with PIC deficiency, ma'am, PIC1 deficiency.
How are you going to reduce the direct hyperbilirubinemia?
Sorry, ma'am?
How are you going to bring down transiently the direct hyperbilirubinemia, doctor? It will cause itching. No?
Ma'am, after this blood transfusion and the removal of the hemorrhagic clot, the direct bilirubin fell very drastically also, ma'am. Probably because of an effect of an exchange transfusion, like because we've taken out the blood mostly. So now her total bilirubin is on control, ma'am. So she's on.
Total bilirubin was 14 and direct was 13, isn't it?
Yes, ma'am. When she presented, yes, ma'am. And it has come down to 4.2, ma'am. The last one which she came for follow-up was 4.2, ma'am.
Okay, okay. Okay, doctor, thank you.
Thank you.
Any more questions from the audience? Okay, let's go on with the last but not the least, last presenter of the day, Dr. Shiva Shankar from Chengai Medical College. Okay. Slide. Please.
Good afternoon, everyone. I'm Dr. Shiva Shankar from the Department of Pediatrics, Chengai Medical College. One of the topic from cough to stones, unmasking layers of anemia and health. My monitor is sir. A 4-year-old girl, Shiny, was brought by her mother with complaints of fever for 6 months. Cough and cold for 4 days. History of presenting illness. Childhood apparently normal before 6 days. After which developed which was a high grade max.
We are getting echo. Kindly use one phone for voice and presentation. Use one system for both presentation and audio.
Childhood developed certain type of fever, which lead to medications associated with triggers, and is often called for cause associated with higher agents. No.
Sorry, Dr. Shivashankar, you are not audible. Dr. Shivashankar? We are very sorry that our presentation is getting some technical issues because of a recently placed TV in our demo room. So kindly excuse us in this regard.
Sir, am I audible, sir?
Yes, right now you can.
Sorry for the interruption. No stay of any
It's
recent
clear now.
travel.
You can continue. Yeah.
No stay of any recent travel. No stay of lethargy. No stay of loose stools, and no stay of refusal of feeds. Antenatal history, it was a spontaneous conception. Iron folic acid tablets were taken, and antenatal scans were found to be normal. And history of anemia in mother during the second trimester, for which blood transfusion was given with the packed cells. And no stay of any pregnancy-induced hypertension, gestation diabetes mellitus, or thyroid disorders. Birth history, it was a term delivery by elective LSCS in view of previous LSCS with a birth weight of 3.2 kgs. Girl child cried immediately after birth, and birth vaccines were given, and no stay of any NECU admissions. Past history, CBC was done on OPD basis, which showed reduced levels of hemoglobin, and no stay of any previous blood transfusions. Ultrasound abdomen done during the illness showed a calculus of size 4.6 millimeters in the lumen of the gallbladder, with no fluid collection, no evidence of intrahepatic biliary radical dilation. And in view of reduced hemoglobin levels, oral iron was started. Developmental history, this child was developmentally normal with all milestones attained appropriate for age. Family history, it was a non-consanguineous marriage, and history of anemia was diagnosed during pregnancy in the second trimester in the mother, and was managed with packed cell transfusion. No history of any gallstones in the family. No family history of recurrent blood transfusions. No family history of diabetes mellitus, hypertension, and seizure disorders. Immunization history, child has been immunized up to 1.5 years of age as per the national immunization schedule. And on general examination, child was conscious, oriented, and afebrile. Pallor was present with no icterus, cyanosis, clubbing, no lymphadenopathy, and no fetal edema. Vitals, respiratory rate was slightly elevated with 46 cycles per minute, and peripheries were warm and pulses were well felt. And on head-to-toe examination, throat showed minimal congestion, and other findings were found to be normal. And anthropometrically, this child falls under moderate acute malnutrition with a weight per height of -2 to -3 score. And on systemic examination, respiratory system showed a bilateral air entry with minimal intercostal retractions and bilateral creps over the right and left intrascapular region, and also in the axillary and mammary regions. And other systemic examination was found to be normal. Course in hospital, child was admitted with a provisional diagnosis of lower respiratory tract infection with anemia and history of cholelithiasis, and baseline investigations were done. Chest X-ray done showed bilateral hilar infiltrates suggestive of pneumonia, and CBC showed a total count of 6,300 with a RBC of 5.75 million cells per microliter and SB of 9 grams per deciliter, and other indices suggestive of microcytic picture with a Menzer index of 8.06 with a red cell distribution with a 19.9% and platelet count of 2.39 lakh per microliter with a neutrophilic predominance of 66 person. And urine routine done was normal, and CRP was non-reactive. LFT done was normal. Blood culture and urine culture was normal with no growth. And a peripheral smear done showed a microcytic hypochromic picture with electrocytosis and anisopoichrocytosis, with the erythrocytosis and pencil cells and teardrop cells with few target cells. And ultrasound abdomen done showed a calculus of 4.6 mm in the lumen of the gallbladder. In view of microcytic hypochromic anemia and reduced Menzer index with gallstones suspecting hemolytic anemia, reticulocyte count, iron profile, LDH levels, and HB electrophoresis was sent. And iron profile showed iron of 14 micrograms per deciliter, total iron binding capacity of 282 micrograms per deciliter, and serum ferritin of 104.3 nanograms per ml, and lactate dehydrogenase of 256 units per liter with a retic count of 1%. And HB electrophoresis done showed HbA of 94.3% with HbA2 of 5.1, which was slightly elevated. So suggestive of beta thalassemia trait with the elevated HbA2 levels. And in view of pneumonia, child was started on injection augmentin and symptomatic management and was diagnosed as a thalassemic trait with gallstones and pneumonia. Discussion: thalassemia is a form of hemolytic anemia of autosomal recessive inheritance characterized by hemolysis and ineffective erythropoiesis. Based on the type of globin chain defect, they are classified into alpha and beta thalassemia. And there is a defective cytoplasmic maturation of erythroid precursors with a defective synthesis of globin chain that results in imbalance of alpha and beta globin ratio. This imbalance causes a precipitation of unpaired globin chain with a premature destruction of erythroid precursors. And the typical age of presentation for thalassemia major is around 6 months of age, and the carrier rate in Southern India is 2 to 3%. Depending on the severity of imbalance, they are classified into thalassemia major, thalassemia intermedia, and the thalassemia minor are trait. And based on the gene involvement in the chromosome, they are classified into major, minor, and intermedia. In thalassemia minor or trait, only one gene and chromosome 16 gets involved, and usually the child will remain asymptomatic. In beta thalassemia intermedia, both the genes and chromosome 16 gets involved, and the presentation would be with mild to moderate decrease in beta gene synthesis and a variable degrees of severity in symptoms of thalassemia major. Whereas in beta thalassemia major, both the genes and chromosome 16 gets involved with a severe decrease in beta globin chain synthesis. The presenting features would be with abdominal swelling, growth retardation, jaundice, pallor, skeletal abnormalities, splenomegaly, which requires lifelong blood transfusions. And pathogenesis of beta thalassemia, there is impaired beta globin chain synthesis with a relatively excess of alpha chain, which leads to abnormal erythroblast. And this erythroblast will die in the marrow mostly, and leading on to ineffective erythropoiesis. That will lead on to anemia, tissue hypoxia, and elevated erythropoietin levels, leading on to extramedullary hematopoiesis and expansion of bone marrow. That will lead to skeletal deformities and hepatosplenomegaly. Some of these abnormal erythroblasts may enter into the circulation that can precipitate the alpha globin aggregates with membrane damage that can lead to extravascular hemolysis in the spleen. And this extramedullary hematopoiesis will lead to increased levels of erythroferrone that suppresses hepcidin levels and increased intestinal absorption of iron with systemic iron overload and secondary hemochromatosis. And with anemia, blood transfusions, which would lead to further iron overload, leading on to secondary hemochromatosis and eventually cardiac disease and death. And this is the skeletal features of a child with thalassemia, with a large deformed skull, frontal and posterior bossing, prominent zygomatic bones and depressed nasal bridge, malocclusion due to overgrowth of maxilla, which may look like a chipmunk facies, and other bony features like expansion of the metacarpal and metatarsal bones, broad ribs, shortening of the long bones due to premature epiphyseal fusion, and a vertebral body overgrowth that can cause cord compression. And on an X-ray skull, it would show hair on end appearance. And diagnosis of thalassemia, CBC findings in thalassemic trait or minor will show mild microcytic anemia with HbA2 levels of more than 3.5% and a high power liquid chromatography. Whereas in thalassemia major, there will be severe microcytic anemia with the target cells and HB levels of 3 to 4 grams per deciliter. And on high power liquid chromatography, the HbA2 levels will be more than 5%, with a fetal hemoglobin of 95%, and there will be no adult hemoglobin. Whereas in beta thalassemia intermedia, there will be moderate microcytic anemia with HbA2 levels of 4%, with a fetal hemoglobin of up to 50%. And the characteristic feature of thalassemic trait which differentiate it from iron deficiency anemia are, it has a Menzer index of less than 13, with a red cell distribution with less than 16, with the ferritin levels more than 12, which can be present or absent, with a relevant family history with no response to iron therapy. And complications of thalassemia includes jaundice, pigmented gallstones, iron overload, hypersplenism, impaired growth with heart failure and arrhythmias. And major treatment for thalassemia includes blood transfusion in case of thalassemia major, with the packed red blood cells at 15 to 20 ml per kg every 2 to 4 weeks once. If the serum ferritin levels are more than 1000 micrograms per liter, chelation therapy must be started, and Deferoxerox is the drug of choice. And on starting a chelation therapy, LFT and RFT must be monitored monthly and on every 3 months once. And supportive treatment with folic acid 1 mg per day, along with the vitamin C, and immunization as per the schedule with pneumococcal vaccines. And newer modalities for therapy includes luspatercept, which is an anti-apoptotic drug which prolongs the lifespan of red blood cells, administered by subcutaneous route. And currently, this drug has been approved for patients about 12 years of age, but currently this drug is not available in India. And ruxolitinib, which is a Janus kinase 2 inhibitor given by oral route, reduces splenomegaly. And gene therapy is currently not available in India. And the curative treatment for thalassemia is bone marrow transplantation. And the optimal age for transplantation is 2 to 10 years. And the criteria includes the child must have an optimal chelation therapy with no organomegaly and organ dysfunction. Coming on to gallstones in children, gallstones in children are very rare, and more than 70% of gallstones are pigmented stones, and 15 to 20% being cholesterol stones, and the remaining is a mixture of cholesterol and organic matrix with the calcium bilirubinate. And these are the types of gallstones: cholesterol stones, pigment, and mixed stones. And pseudolithiasis, ceftriaxone gets mostly eliminated through kidney and remaining by the biliary system. And ceftriaxone binds with calcium ions, causing biliary sludge and lithiasis, which can lead on to biliary colic, cholecystitis, and pancreatitis. Gallstones, the complications of cholelithiasis are more common in thalassemia major due to the ineffective erythropoiesis and peripheral hemolysis with iron overload. And gallstones in hemolytic anemia are often referred to as pigment stones with a black pigment, and the content of the black pigment is a cross-linked network of polymer bilirubin, and moreover, about 40 to 80% will have a radio-opaque appearance. Approximately 55 to 63% of patients with thalassemia intermedia will suffer from gallstones. The prevalence of cholelithiasis is higher in thalassemia intermedia compared to thalassemia major, and the reason would be ineffective erythropoiesis with peripheral hemolysis that results in increased bilirubin production. That is the reason for cholelithiasis being higher in thalassemia intermedia patients. And the risk of gallstones are increased in thalassemia minor compared to general population with an odds ratio of 2.4 based on an adult study, but major pediatric data are currently not available, even though it is less than the major and minor groups. And the algorithmic approach to pediatric cholelithiasis. And pediatric cholelithiasis can be idiopathic, which can be asymptomatic and symptomatic. In case of asymptomatic idiopathic cholelithiasis, UDCA therapy for 6 months must be given, which may undergo spontaneous resolution. But if unresolved, cholecystectomy is the treatment of choice. Whereas in symptomatic idiopathic cholelithiasis, which may present with biliary pain and complications not responding to medications, cholecystectomy remains the treatment of choice. Whereas in ceftriaxone-induced pseudolithiasis, UDCA therapy for 6 months must be started, which may undergo resolution, and surgery is needed only in case of complications, which is very rare with pseudolithiasis. And in case of pigmented stones, cholecystectomy remains the treatment of choice. Whereas in total parental nutrition-induced cholelithiasis, UDCA therapy remains the treatment of choice for 6 months, which may undergo resolution, and the surgery is rarely indicated. Thank you.
Thank you, doctor, for the excellent presentation. Was any genetic studies done on this child?
Uh,
See, and
Hello?
see, other thing is
Hello?
your plan for genetic study. Yes?
Hello?
Am I audible? Am I audible?
Yes, ma'am. Hello?
Am I audible?
Yes, ma'am.
Yes, ma'am.
Was any genetic studies done on this child?
Yes, ma'am. We are advised for genetic study and genetic counseling for the family, ma'am.
Was any genetic studies done, doctor?
Dr.
Hello?
Shaktivel, I hope Dr. Shaktivel is online. You can just enlighten
Yes,
on.
yes, ma'am.
No, I want to know about any genetic studies done.
We have planned for genetic study for both for the child, and we have planned for genetic counseling also, ma'am, for the next pregnancies. Since mother is also having has had anemia, we advised genetic studies even for the mother, ma'am.
That's what the mother had anemia for which she was transfused. At least
Yes,
a
ma'am.
baseline HPLC could have done for the mother to identify if she's a trait, no?
Sorry, ma'am.
No, a baseline high performance lipid chromatography can be done for the mother to identify if she is also having any thalassemia trait
Yes, ma'am. That is the next line. So we
before
have
the
given
genetic
for,
studies.
yes, ma'am. We have sent sample for HPLC for the mother, ma'am, and we have planned for genetic studies for the child and genetic counseling for the family for subsequent pregnancy, ma'am.
What's the role of hydroxyurea?
Hydroxyurea actually in the thalassemia major it has a role, ma'am, but for in major it has role in reducing the transfusions. Again in intermediate again it has some role, but in minor and here in this case with the gallstones not much effects have been demonstrated, ma'am. So in
You
major
have
and
known about
intermediate.
the latest treatment of genetic gene therapy, isn't it? Which is not available in India. Actually,
Yes,
now
ma'am.
there are drugs have come up which will help in editing the genes. Unless we do the genetic studies, we cannot edit the genes. Drugs like Casgevy and all have come, which you can
Yes,
do
ma'am.
the gene editing, and we can also transfuse corrected autologous stem cells. That is,
Yes, ma'am.
previously we used to fuse transplant hematopoietic stem cells from a normal individual. But now you can take the patient's own stem cell, correct the genetic defect, and then you can give it to the same patient. Corrected autologous stem cell transfusion.
Yes, ma'am. Yes, ma'am. Yes, ma'am. Currently, gene therapy in US it is in phase 3 studies, ma'am. Right now, like you said, it is not available in India, ma'am. Maybe in future, definitely it will be of help. With genetic studies, will help us further in guiding towards the further management, ma'am, including genetic gene therapy and stem cell transplantations.
Thank you, doctor. Thank you for the excellent presentation.
Thank you, ma'am.
Thank you all. Just a reminder, everyone would be getting an e-certificate. Kindly share your mail ID, the participants, to the either to the IAP Chengai group or to my number, which I have shared in the chat box.
Thank you all for participating. And thank you the Annex Canteen as well as Thoran for sponsoring today's snacks. Thank you all.
Thank you everyone for joining the meet today. We'll meet for the next edition of our Chengai Pediatric meet. Thank you.
who are getting admitted in